My screen now.
Yes, now.
47 men comes to the office because of a 6-month history of aching, burning pain in both legs. Initially, he had pain only after he walked for 1 mile, and now the pain occurs after he walks 1.5 block. What? No, 1 mile. Wait. Initially, he had pain after he walked for 1/2 mile, but now pain occurs after he walks 1/2 block and resolves only after he rests for a minute. He says his symptoms interfere with his job's construction as a worker. On a large work site, he is able to ride and exercise bicycle without pain. Hmm. He has hypertension, diabetes, hypercholesterolemia medication, the metformin, and atorvastatin. 2 years ago, he underwent orchiectomy and retroperitoneal radiation therapy for testicular cancer. Blood pressure is fine. All the vital signs fine. Exam shows absence of left testis. Ankle brachial index is 0.9 in both feet, which is, wait, is it normal? I think so, yeah. Deep tendon reflexes are moderately decreased at the ankle. Sensation to pain print is decreased over the feet. The remainder of the exam shows no abnormalities. MRI of the lumbosacral spine shows narrowing of the spinal canal secondary to congenital stenosis and superimposed degenerative changes. Which of the following is the most appropriate next step in management?
Okay. It's lumbar spinal stenosis. Spinal stenosis has like claudication pain. It is indicated in here. Like he had pain only after he walked for 1.5 mile, but now the pain occurs after he walks 1/2 of block and resolves only after rest. So looks like claudication pain and decrease the claudication distance, and sometimes rest pain can happen in spinal stenosis. And we know the spinal stenosis there is a sign. Can you remember the sign by which we can diagnose the spinal stenosis?
Is it the one when you lean forward it gets better, or it's not that
Yes,
one?
yes, that was shopping cart sign.
Okay.
Shopping cart sign like forward bending relieves the pain and extension like forward flexion relieves the pain and extension actually increase the pain. That is the shopping cart sign. Okay. So lumbar spinal stenosis refers to the narrowing of the lumbar spinal canal which results in compression of the lumbar spinal roots or spinal cord. Patient may present with the symptoms of radiculopathy, including back pain that radiates to the blocks that radiates to the buttocks and the legs, uh, leg numbness, paresthesia or weakness, hip extension increases pressure on the nerve root while flexion of the hips while riding a mechanical bicycle relieves the pressure. Consequently, patient may demonstrate neurologic claudication in which extension of the hip standing or walking downhill leads to symptom, and the most common cause of lumbar spinal stenosis is degenerative joint disease and osteophytosis, which often occurs with advanced age and occupations involving manual labor as in this patient. The diagnosis is confirmed by MRI. Treatment involved NSAIDs, physical therapy, surgery. In patient with severe and progressive symptoms and clear stenosis on imaging as the cause of the lumbar radiculopathy, laminectomy, or removal of vertebral lamina to decrease the pressure on the nerve root is an appropriate next step in the management. Conservative management is more common for stable radiculopathy symptoms. Okay.
Theory B, as in boy.
Yes, ibuprofen therapy and bed rest is unlikely to lead to symptoms improvement in this patient. Though ibuprofen is commonly helpful, bed rest can lead to worsening symptoms. Physical therapy with goals of muscular stabilization and correction of posture is more likely than bed rest to relieve radiculopathy pain from the lumbar spinal stenosis. For patients with severe and progressive symptoms, a laminectomy may be performed. So laminectomy may be recommended. Okay.
23, woman epilepsy comes to the clinic because she and her husband would like to conceive during the next year. She began having generalized seizure at relapsing seizure at 11 years old and has been taking valproic acid and etoxopamide daily twice daily since 14 years old. Her most recent seizure was 2 years ago. At that time, her dosage of valproic acid was increased. Symptoms have been well controlled for 2 years. She has no other serious illness, doesn't take medication. She and her husband use condoms consistently. Examination shows no abnormality. Without prophylaxis, which of the following anticonvulsant mediated adverse effect is most likely to develop?
Okay, it's a valproic acid, and we know that valproic acid cause a fetal neural tube defect. And the cleft lip, cleft palate is done by the phenytoin, isn't it?
Mm-hmm.
Phenytoin
Mm-hmm.
actually cause the gum hypoplasia, cleft lip, cleft palate. Okay, so maternal valproic acid as the patient is epileptic. So especially with the use of the, especially without the use of the folic acid supplementation is associated with fetal neural tube defect. So maternal valproic acid, especially without the use of folic acid supplementation, is associated with fetal neural tube defect. Pre-pregnancy visits allow a healthcare provider to optimize patients' chances to have successful pregnancy and healthy child. The purpose of these visits should be identify the risk to the mother or the fetus and to intervene as possible to reduce these risks. Typical assessment include evaluating medical condition, epilepsy, obesity, diabetes, hypertension, exposure to teratogen medication, social behavior, transmitted infection, screening in patients at high risk, multiple sexual partner, no barrier protection. Finally, intervention include folic acid supplementation, medication changes as needed, and abstinence from substance use, optimization of medical condition and required vaccination. Folic acid supplementation in pregnancy is critical as a deficiency can cause fetal neural tube defect as spina bifida. This risk is increased by the medication that affect folic acid metabolism such as valproic acid because the patient's seizures are well controlled with her current regimen. It is reasonable for her to consider continuing the medication. However, to prevent fetal neural tube defect, she would require more folic acid. She would require more folic acid supplementation than would be prescribed for a pregnant patient not using medication that affects the folic acid metabolism. Okay.
Okay. Next. 25, woman comes to physician because of 3-day history of low-grade fever, sore throat, generalized muscle aches, and fatigue. She also has moderate neck pain radiating to her jaw and ears during this period. Okay. She has no history of serious illness, doesn't take medication. She's alert and in no distress. Temperature is high. BP pulse is high. Respiration normal. BP normal. Thyroid gland is diffusely tender and slightly enlarged. Exam of the head, ears, and nose and oropharynx are normal. Serum studies with TSH concentration of zero point 0.5, which is, I believe, normal. Let me double check. Where is it? Thyroid, TSH right here. Zero point 0.5 is normal. And T4 is T4. Wait, is it the UGL? This one is high. Yeah, T4 is high. Thyroid scan shows decreased uptake. Which of the following is the most appropriate next step?
In here, there is tender enlarged thyroid gland, so only one diagnosis: decurrence thyroiditis or subacute thyroiditis. And in subacute or decurrence thyroiditis, we give only the painkiller. We can give acetaminophen, we can give NSAIDs, and that's it. Okay. So subacute or decurrent thyroid, also known as subacute granulomatous thyroiditis, is a rare form of thyroiditis characterized by inflammation of the thyroid gland and the presence of granuloma. Treatment typically includes NSAIDs, non-steroidal anti-inflammatory drugs such as ibuprofen, corticosteroid to reduce the inflammation, corticosteroid to reduce the inflammation of the pain. This condition is typically preceded by a viral infection. This condition is preceded by a viral infection such as upper respiratory tract infection, that is, and is more common in women. Symptoms usually include pain and tenderness in the thyroid tissue, fever, fatigue, and swollen thyroid gland, along with the symptoms of hyperthyroidism, anxiety, tremor, weight loss, diarrhea, menstrual irregularity, hot flashes, hypertension, sweating. Subacute thyroiditis is usually self-limiting, and the thyroid gland returns to the normal function within a few weeks or months. However, in some cases, the function may have experienced temporary or permanent hypothyroidism following the initial period of inflammation and genetically transient hyperthyroid symptoms. Subacute thyroiditis should be suspected in patients with tender enlarged tender thyroid, history of viral illness, and or thyroxine concentration with decreased TSH concentration as seen in this patient. Okay.
Previously healthy 4-month-old girl brought to the ED because of 2-day history of fever. She has been feeding poorly and has vomited 4 times within the past 24 hours. She has not had diarrhea. Immunizations were up to date at age 2 months. On arrival, she appears somnolent and irritable. She's at the 50 percentile for length and head circumference and 25 percentile for weight. Temperature is super high, pulse is high, respiration high. Exam shows full anterior fontanelle. The remainder of the exam is fine. Lumbar puncture is performed. Gram stain of the CSF is shown. Which of the following is the most likely organism?
Mm.
It looks like cocci impairs.
Yes, looks like cocci, but a gram positive cocci, uh, there isn't it blue stain, and gram negative is red? Is there anything like that? I
No.
forgot the microbiology actually.
Yeah, there is something like that. Yeah, yeah. Gram
And
positive is.
in 4 month old girl or 4 month old baby, there is possibility of having neonatal meningitis with the help of gel group B, E. coli, and Listeria. These three organisms can cause these three organisms can cause neonatal meningitis or bacterial meningitis. Is there any clue of group B streptococci
Group
apart
B,
from gram stain?
Group B streptococci. Mm, Group B will be the no, because Group B is what the galaxy. That's usually newborn, right?
Yes, E.
Mm,
coli can happen and Listeria can happen. These three can cause neonatal meningitis. We know that, like gel.
okay, okay.
So how we can differentiate? Just looking at the cocci.
Yeah, I guess. But E. coli, yeah, because this one you can see that is. I think this one is cocci in pairs, and E. coli it's bacilli. It's not cocci, right?
Yes,
Yeah, it's bacillus, so it cannot be that. And then listeria is the which one is it? I think it's bacillus too. It's gram positive
Listeria
bacillus.
is a gram-positive bacillus. Yes,
And group B are galactic. Mm,
Group B Achalasia is actually gram-positive cocci in pairs or chains.
in pairs of chains. Okay, I don't know. I think yeah, I think because it's not a newborn here, that's why I don't know why
But
it's not good.
I am very confused with the background. The background is red. Usually the background like blue background like gram-positive organism. Okay,
Oh,
I'm
I thought
reading.
it was the organism itself that you look at, not the background.
Okay,
I thought
maybe
it's the
that
thing
is
here.
another
Yeah.
thing. Yes.
Hmm.
So bacterial meningitis, patients with fever, headache, nuchal rigidity, altered mental status, typically following a program of upper respiratory tract infection in patients. Nuchal rigidity is common. Physical examination may show a present Carning and Brudzinski sign indicative of meningeal irritation, and can also show focal neurologic symptoms and signs. Focal neurologic symptoms or signs of increased intracranial pressure, which includes bulging of anterior frontal alley in infants. Petechiae may be present. Lab studies will show leukocytosis, and coagulation study can show signs of DIC with thrombocytopenia, decreased fibrinogen, increased D dimer depending on the specific pathogen. CSF evaluation is the most appropriate. CSF evaluation is the most appropriate initial diagnostic step, which will show an increased opening pressure, and increased white blood cell count with prominent neutrophil, protein cepha concentration, and uh, increased protein concentration and decreased glucose concentration. Culture of the CSF to diagnose the bacterial cause, to distinguish between the viral and the fungal, or alternative diagnosis to cause pneumonia, bacterial pathogen beyond the newborn period. It appears as CSF culture as an extracellular gram-positive purple on gram staining and lancet shaped coccus.
Yep. So that's not coccus. That's lancet shape. Yeah, Diplococcus. Yeah, yeah.
Okay.
Remember from sketches the
Yes,
one with the
the
thing. Yeah,
lens,
lancet shape, and it's two of them, so it's the lancet shape. Yeah, that was
the
your only clue. Yeah.
the the thing like one is having the hat and another is not, like meningo streptococcus pneumoniae and
That one. That one. That one.
yes,
Yeah, yeah. But it's not the hard one. It's the you get what I'm saying. It's the thing that he has in the hand,
the lancet, yes.
the lancet. Yeah. So I
Okay,
think that was your only clue here. And you can read why it's not list E. coli and listeria and all the other
So
the ones.
Lancet coccus. Okay,
Mhm.
treatment is vancomycin and third generation cephalosporin and steroid. And E. coli and Listeria monocytogenes and group B streptococcus are common pathogens of neonatal meningitis. They are less common cause of meningitis outside the neonatal period. E. coli is gram-negative red color on gram stain, red colored on gram stain, red colored on gram stain. Gram-negative bacilli. Listeria monocytogenes is gram-positive bacilli. And Streptococcus agalactiae, which colonize the vaginal tract, is transmissible during delivery, is gram-positive coccus. Okay.
Mhm. Next, progress of 63 men who has COPD returns to the office for a follow-up visit. His COPD has progressed during the past 3 years. He smoked cigarettes for 48 years but quit a year ago. He continues to have chronic cough, dyspnea on exertion, and episodes of wheezing. He says he often sleeps in his recliner so that his snoring and coughing would not bother his wife. Current medication, inhaled albuterol, budesonide, ipratropium for the past 2 months. He received a pneumococcal polysaccharide vaccine 23 2 years ago. He's retired post-worker and is frustrated because he's no longer able to walk from the car to the poker room at the local community center to play with his friends. Today, the pulse is fine and regular, pulse BP fine. He appears large and has a battered chest. Breath sounds are decreased and scatter wheezes heard. No gallops or murmurs. The pulse count is high. Hemoglobin is, I believe that's normal. After the patient receives nebulized albuterol, pulse oximetry on room air shows oxygen saturation of 86. Which of the following is the most important factor in this patient? History and physical exam in determining his prognosis. Hemoglobin, let me see. I believe that's normal though.
Which one?
Hemoglobin, yeah, it's normal, it's normal. Okay.
So it's progressive dyspnea on exertion. COPD is a disease characterized by decreased lung function. COPD is the disease characterized by decreased lung function from a combination of chronic bronchitis and emphysema resulting in airflow obstruction on expiration. Airflow obstruction on expiration. Breath sounds are decreased because of reduced airflow and prolonged expiratory phase as the pathology narrowed airway are further compressed by positive intrathoracic pressure during expiration. Heart sounds may be distant, secondary to emphysematous lung changes, and sound is transmitted. Oh, where
Yeah.
okay, sound is transmitted poorly through the air relative to normal lung tissue. Pulmonary abnormalities can be evaluated by pulmonary function testing, which includes spirometry, full body plethysmography, and single breath diffusion capacity, arterial blood gas analysis, pulse oximetry. So spirometry is the most useful. So spirometry is the most useful uh, most uh, useful in diagnosing obstructive lung disease, which is defined by decrease in the ratio of the volume of air forcefully expired in the first second of expiration to the total lung volume expelled during the expiratory phase, FEV1 by FBC. The severity of the obstruction is graded by the amount of FEV1 reduction compared to the predictive value. Treatment is focused on smoking cessation, smoking cessation and supplemental oxygen to decrease delivery. Symptoms are managed with inhaled short-acting beta agonist and long-acting beta agonist, short-acting beta agonist, long-acting beta agonist, muscarinic antagonist, and glucocorticoid. This patient continued worsening dyspnea on exertion despite appropriate medical therapy is the most important factor for determining the diagnosis. Prognosis in COPD depends on the functional ability of the lung to serve its progressive organ failure and failure of the organ to respond to appropriate physiologic demand. Okay.
Can you read the other multiple, please?
Yes. Barrel shaped chest, barrel chest, and decreased breath sound. Barrel mm, chest, decreased breath sound, and failure of inhaled corticosteroid and failure of inhaled corticosteroid and snoring offer insight into the presence, severity, and chronicity of the patient's COPD, but have little prognostic value. Failure of inhaled corticosteroid can be viewed as a prognosticator for poor outcome. However, the patient's progressive dyspnea on exertion, despite primary features of COPD, it may exist as benign snoring or the result of upper airway obstruction, obstructive sleep apnea, exist in both of which can exist independent of the presence of COPD. So chronic obstructive pulmonary disease is a lung disease characterized by airflow obstruction. Chronic symptoms are improved with inhaled long-acting beta agonist and muscarinic antagonist, glucocorticoid, progressive dyspnea on exertion, and adequate medical therapy indicates poor prognosis. Okay.
Okay. Next. 52 women with diabetes is admitted to the hospital because of 3 week history of persistent pain, edema, erythema of the left foot. She has not sustained trauma to the foot. She has no history of foot ulcers or wounds. Medication, insulin, and aspirin, vital signs normal. In exam, the left foot shows um, diffuse edema, erythema, warm. There is no tenderness to palpation. Dorsalis pedis and posterior pulses are fine. Sensation to touch and fingerprint is decreased in the stocking. Distribution bilateral, the remainder of the exam is fine. Hematocrit, I believe that's fine. ESR, I believe, is high. Uh, Uric acid, I don't know, I'll check. Antibiotic therapy is started. 3 days later, examination findings are unchanged. A repeat leukocyte count is still within is still normal. Blood cultures obtained before administration show no growth. An X-ray of the left foot is shown. Which of the following is the most likely diagnosis? I think just by looking at the X-ray, you could know.
Yes. Looking
Yeah.
at the X-ray, and he is diabetic for prolonged period. He is on insulin, and so looks like diabetes patient. Foot deformity looks like neuropathic arthropathy or Charcot joint. Okay. So neuropathic arthropathy, also known as Charcot joint, is a progressive degenerative condition that affects the bone, joints, soft tissue of the foot and ankle. It is caused by damage to the nerves in the feet, leading to decreased sensation and loss of protective reflexes. This results in increased weight bearing and trauma of the affected area. Over time, joint deformity, fracture, and dislocation can occur. Risk factor for neuropathic arthropathy include diabetes, peripheral neuropathy, neurologic condition that affects the sensation, It is more common in individuals with history of trauma or operation of the foot and ankle. Treatment for neuropathic arthropathy typically involves offloading weight from the affected area through the cast or removal boot. Physical therapy and orthotic device may be used to support the affected area and prevent further damage. In severe cases, operative repair may be required to correct joint deformities and stabilize the affected area. Complication of the neuropathic arthropathy include chronic pain, joint deformity, and increased risk of foot and ankle infection. Amputation may be required in severe cases. Given this patient history of insulin use, stockings like sensory loss and loss of evidence from neuropathic arthropathy is the most likely of the diagnosis. Okay.
Can you read A?
Yes. Advanced osteoarthritis and collapse and joint destruction secondary to advanced gouty arthropathy are unlikely cause these patient symptoms. Radiographic findings are inconsistent with these diagnoses given a 3-week history of sorry which line in severe cases operative repair may be required to correct the joint deformity and stabilize the affected area. Complication of the neuropathic sorry sorry I okay
Well, you're reading A.
I am reading a okay. Advanced osteoarthritis and collapse and joint destruction secondary to the advanced gouty arthropathy are unlikely causes of these patient symptoms. Radiography findings are inconsistent with these diagnoses given the 3-week history of symptoms, lack of history of trauma or arthropathy, lack of tenderness or palpation on examination. Osteoarthritis presents with progressive joint pain and stiffness that worsens with increased use. The knee is most commonly affected. The knee is most commonly affected, followed by hip and spine. Risk factor for osteoarthritis include age, obesity, genetics, and high risk trauma. Gouty arthropathy is a progressive disease that presents with erythema, warmth, tenderness, palpation as a result of uric acid crystal deposition into the joint. Okay.
Okay. 67 woman comes to the physician because of 5-day history of progressive shortness of breath with walking and climbing. She has COPD. Okay, current medications include inhaled albuterol, ipratropium, and horapelnison. She smoked 2 packs of cigarettes daily for 40 years, but stopped 5 years ago. Her pulse is normal, respiration a bit high, blood pressure normal. Pulse oximetry on room S is 93. Examination shows pale conjunctiva. Red sounds are decreased bilaterally. Hard sounds are distant. The spleen is palpated 5 centimeters below, so it's high, it's big. Remainder of the exam shows no abnormality. Labs, hemoglobin, I believe, is low, and hematocrit is low too. Leukocyte count is super high. I believe neutrophils are high. Let me double check all that. And lymphocytes are normal. There is no low metamyelocytes and myelocytes and a little bit of blasts. Platelet count is low. Which of the following is the most likely explanation for these findings? Ugh,
Okay, myelocyte, metamyelocyte, and the features looks like leukemia, chronic myelogenous leukemia. Okay, CML. In CML, there is like lab low, leukocyte alkaline phosphatase is low. It is not given here. Lab is low, and in CML there is BCR-ABL tyrosine kinase. Can you tell me the name of the drug we give in the CML?
Oh no, what drug is
Okay.
it?
Imatinib, nilotinib, dasatinib.
Oh yeah, yeah, yeah.
Yes, BCR-ABL tyrosine kinase. Okay. So this patient, hmm, most likely CML, which commonly presents as incidental lab findings in an asymptomatic patient. In the chronic phase, patients may also present with fatigue, night sweat, weight loss, splenomegaly, fever. CML is defined by Philadelphia chromosome translocation between the chromosome 9 and 22. Typical lab findings in CML include hyperleukocytosis, which is present in this case. Hyperleukocytosis. Okay, leukocyte count is 1 lakh. That is hyperleukocytosis. So hyperleukocytosis, which is present in this patient with an increase in nearly myeloid cell line. Leukocyte count is very high, with an increase in all myeloid cell lines. Peripheral blood smear will show a diverse array of immature and partially mature cell of the granulocytic lineage with basophilia. And in CML there is basophilia. Okay. Leukostasis is a condition in which there is hyperleukocytosis leads to end organ damage from occlusion of the capillary by malignant non-distensible cell, which is uncommon in CML because malignant cells are well differentiated and pliable. These contrast with conditions such as acute myeloid AML and ALL, in which circulating blast cells which are large and not particularly pliable easily lodge into capillaries to cause pulmonary and neurologic complication. Treatment of CML is primarily with tyrosine kinase inhibitor, imatinib, dasatinib, nilotinib. As routine labs, such medications are effective, often results in complete molecular response in remission with several months of initiation. Okay,
The myeloid cells are which ones again? The myeloid lineage, sorry.
myeloid lineage are myelocytes, metamyelocytes. Usually in the CBC, you will not see in the myelocytes, metamyelocytes. Usually
No, like
metamyelocytes is not given in the,
no, I
sorry,
mean like the myeloid. Since they say the lymphoid lineage is B cell, T cell, so the myeloid lineage is like everything else.
maybe yes. Myeloid lineage is everything else apart from
Okay,
B and T lymphocyte.
yeah, that's it.
Look, the B lymphocyte, like lymphocyte count is low
Mm-hmm.
and the other count is higher, and
So
there is hyperleukocytosis also, like leukocyte count is 1 lakh.
mm, okay. Lineage versus lymphoid. Okay, it's NK cells, B cells, T cell, NK cells are the lymphoid, and myeloid is yeah,
Rest
red
of
blood
the
cells,
cell.
everything. Okay, get it, get it. So here they say all the myeloid, so yeah, that's what the leukocyte count is super high. Okay, got it. Next, for 57 woman comes to the physician because of substernal chest pain since discomfort since awakening 3 hours ago. She has had no injury or heavy exertion. She ate a greasy meal for dinner last night. She has not had any other symptoms. She has fibromyalgia and hyperlipidemia and MDD. Current medication ibuprofen, atorvastatin, fluoxetine. She has never smoked and doesn't drink alcohol. She's mildly distressed. BP pulse is fine and regular. Examination shows mild tenderness to palpation of the chest wall. Serum studies, sodium is fine, potassium is fine, chloride fine, bicarb fine, urea fine, creatinine fine, I believe, yeah, CK, I don't know, they don't give it here. And troponin is zero point 0.1, I guess it's high. Creatinine kinase, I don't know, I'm guessing it's high. An ECG shows normal sinus rhythm and 1 to 2 ST depression in late V3, V4. Which of the following is the most likely explanation for these findings?
Okay, this is acute coronary syndrome. In acute coronary syndrome, in this term, there is three things like unstable angina, non-ST elevated MI, and ST elevated MI. So this patient, substernal chest pain, increased troponin, and ST depression in V3, lead V3 and V5. A presentation consistent with acute coronary syndrome. So, acute coronary syndrome encompasses a spectrum of disease like unstable angina, non-ST elevated myocardial infarction, and ST elevated MI. ACS classically presents with acute chest pain often radiating to the neck, jaw, arm, along with shortness of breath, nausea, and lightheadedness. Risk factor include history of smoking, diabetes, hypertension, hyperlipidemia, obesity. If the infarction results in left ventricular dysfunction, patient may have experienced cardiogenic pulmonary edema resulting in shortness of breath, tachypnea, hypoxia, audible crackles, and S3 or F4 gallop. Diagnosis is made using clinical history, analysis of the biomarker, increased in both ST elevated MI and non-stable MI, but normal in unstable angina. An ECG may show ST elevated elevation or depression or inverted T wave and Q wave in a particular vascular distribution. Treatment is antiplatelet drug plus anticoagulant pain control devascularization through angioplasty. And complication is papillary muscle rupture with subcutaneous MR, dysarrhythmia, cardiogenic shock, pulmonary edema, ventricular rupture post infarction, pericarditis. So, in just looking at the what is your diagnosis? Like what kind of ACS is here?
It's not elevation. Troponin is high, so
Non-ST
non-ST.
elevated MI. Yes, there is
Mm-hmm.
ST depression and troponin high, so it is non-ST elevated MI. And in non-ST elevated MI, there is subendocardial infarct, and in ST elevated MI, there is transmural infarct. The infarction is transmural. Not written here, just I have said.
So the unstable won't have troponin high, right?
Yes, unstable, unstable. Sorry, in unstable MI, there is sorry, in unstable angina.
Mm-hmm.
So in unstable angina, their troponin may not be high. Yes, troponin is not high.
Next. 27 women gravid at 2 para 1 at 18 weeks gestation come to the pediatrician for routine prenatal. Her 5-year-old son recently received the diagnosis of erythema infectiosum, so fifth disease. Examination shows no abnormality. Which of the following is the most appropriate next step?
Okay. So measurement of specific IgG and IgM. This patient has a fifth disease like parvovirus B19. So human parvovirus B19 in the context of acquired infection while pregnant is typically a mild viral syndrome that may include a rash, fever, chills, headache, myalgia, arthalgia, nausea, vomiting, pain, abdominal cramping, diarrhea, mild respiratory symptom. The rash seen in adult human parvovirus B19 infection is variable in distribution, less likely to demonstrate the characteristics red cheek appearance seen in children, and may not be present at all. It is generally self-resolving seldom carries a significant burden of morbidity in otherwise healthy people. There are they are there may be consequence of maternal human parvovirus B19 for the developing fetus. However, especially infection is acquired, if the infection is acquired in the first or second trimester, human parvovirus B19 has tropism for bone marrow and infects erythroid progenitor cell and however, which can cause fetal anemia. Fetal anemia may present as fetal tachycardia, high output heart failure, hydrops fetalis, and death. Parvovirus is a potential cause of fetal myocarditis. It's a potential cause of fetal myocarditis. This pregnant patient has been exposed to parvovirus via her son, 5-year-old son, and because symptoms are mild and may go unnoticed, determining whether she has been infected through measurement of serum specific IgG or IgM concentration is the most appropriate next step in the management. Increased concentration of the IgG in the absence of IgM indicates previous infection, while increased concentration of both indicates current or recent. So both increased current or recent infection has and not this patient has been infected will help to guide further management of her pregnancy, including the need for an additional testing or sonography. Okay, so if it is
Oh,
positive, then what we should do?
uh, wait, I thought they said it here. I don't know. I never found a question like that. What do
Okay.
they give for parvovirus? What's the treatment for parvovirus?
I don't know any treatment of the parvovirus. I
No,
know
I don't think I've ever found a question.
we
I don't
know
think
we know
I've
the
found a question.
complication. We know that
Yeah,
parvovirus can cause aplastic anemia, like
he says here supportive and self-limiting. I don't
parvovirus
think.
is like the baby with the plane, the aplastic anemia, and
Yeah,
hydrops fetalis, and a bone
yeah,
causing osteomyelitis, and then the aeroplane. I know that figure. Okay.
yeah. It doesn't say anything about. It just says supportive and self-limiting. So I don't know.
If the
I
mom
don't.
is infected and there is a baby in the utero, is there anything we need to do?
It doesn't say. It doesn't. At least it doesn't. I never heard a question like that in it. Here it doesn't go to that. It just says treatment, supportive care, and self-limiting. So I don't know. I guess
Okay.
at that point you will just tell the mom. The only question I think they can bring out there is okay, you should counsel the mom of, oh, there is that possibility of hydrocephalus.
possibility possibility of hydrocephalus, then I
Or,
think that uh, like abortion or delivery, this type of thing, because
yeah, but here they cannot do delivery because she's only like 18 weeks. Even if she's 18 weeks, so that would even, I guess, abortion. I guess at that point, like
okay,
elective abortion, right?
yes, maybe.
Yeah, yeah. Okay. Next. 17 girl comes to the office for contraceptive counseling. She requests a specific brand name oral OCP because she heard from her friend that it works well and also helps control the acne. The physical physician informs her that this particular drug has a higher copayment and there are similar oral contraceptives that will provide the same benefits. The patient refuses any other OCP, oral OCP, and she says that she has a good job and can afford the more expensive one. Which of the following is the most appropriate response by the physician?
Okay, so prescribe the oral contraceptive the patient requested. So this physician is facing a conflict between the ethical principle of autonomy and beneficence. The physician believes it. The physician believes it would be beneficial to this patient to use an oral contraceptive that is both effective and cost effective as opposed to one that is effective but not cost effective. However, the principle of the autonomy posits, posits that capacitated patients have the right to make their own decision regarding of their health care, even if the physician disagree with the decision. As such, the physician should prescribe the oral contraceptive that the patient requested. Exception of to this ethical guidance is when the patient asks for an intervention that is likely to directly harm their health or bodily integrity without providing significant benefit, like prescribing a benzos for a patient with an active substance use disorder and performing medically unnecessary surgery. In this case of in the case of this exception, the physician may invoke their duty to do no harm and non-maleficence and decline the patient's request. Okay.
Okay, next. 21 woman comes to the physician because of one day history of redness and itchiness of her right eye. When she awoke this morning, she had mild crusting over her eyelashes. She has not had fever, dry mouth, muscle aches, or rash. She has no allergies or history of serious illness, doesn't take medication. She was in preschool. In a preschool, vital signs are normal. Exam shows moderate, diffuse injection of the right conjunctiva. Which of the following is the most appropriate pharmacotherapy?
So it looks like viral conjunctivitis because there is conjunctival injection and there is no pass. Okay. Uh, Viral conjunctivitis presents when with bilaterally or sequentially bilateral follicular conjunctivitis, tearing, blurry vision, watery discharge, and irrigation. Symptoms typically begin in one eye. Symptoms typically begin in one eye prior to spreading to the contralateral eye. Adenovirus, the most commonly implicated in the pathogens of viral conjunctivitis. Almost most patients do not require conjunctival, although mm, although most patients do not require Conjunctival swabs for confirmation. The infection is commonly acquired through direct contact from contaminated surface. Patients with certain environments such as preschool or medical setting are particularly high risk. Patient may also note a coincident or recent upper respiratory tract infection and may have symptoms of fever, rhinorrhea, preauricular or submandibular lymphadenopathy. Most patients improve with conservative management include lubricating eye drop and cool compresses. For this patient, no pharmacotherapy is indicated. Viral conjunctivitis is highly contagious and patients should be counseled to stay home from work or school to wash their hands frequently. The funny thing that is in our country, patients with viral conjunctivitis, we prescribe like people wants the antibiotic like moxifloxacin, which is used in actually bacterial conjunctivitis, but
Bacteria. Mhm.
yes. So actually moxifloxacin and like antihistamine and like eye drop, like liquid eye drop, which is lubricating eye drop. These three
Mhm.
things can is given.
For viral?
Yes,
Oh, okay. Because they cannot, okay, because they just don't want to, they want to be safe and be like, okay, we think it's viral, but just let's just, so it's not bacterial, just to make sure it's not bacterial, let's give them all of that.
like if you the problem is multiple. If you go to a physician and if you don't give anything, he will go to another physician.
Yeah, yeah, that's
So
true.
that is the problem.
That's true. I
And
understand. Because
in US, like the other physician can figure it out that you go to that physician, but in our country it is not possible because patient will hide his prescription.
uh, no, but I feel them because remember when I had my sore throat and they kept telling me, no, it's not, but it's fine. You're gonna be fine. It's just supportive care support. And I was like, no, my throat is bad. Like I need something. So
Yes,
you want, yeah. So I understand, but yeah, I get it. Next, okay. 32 women brought to the ED because of 24-hour history of increasing severe lower abdominal pain. Okay. She has been unable to eat anything for 12 hours because of the nausea. She has been taking sulfasalazine for ulcerative colitis for 6 months. Her temperature is a bit high. Examination shows distended tympanic abdomen. There is tenderness to palpation of the lower quadrant. Bowel sounds are decreased. X-ray of the abdomen shows dilated colon and gas in the bowel wall. That's the key. Which of the following is the most appropriate next step?
this patient has ulcerative colitis and there is dilated colon. So what is your diagnosis? An ulcerative colitis
Is it the
patient,
top?
yes,
Okay.
it's a toxic megacolon. Because ulcerative colitis patient, the complication can happen like toxic megacolon. Okay, ulcerative colitis is a type of inflammatory bowel disease that results in that results in inflammation and ulceration of the colonic mucosa and submucosa, typically beginning in the rectum, and advancing proximally in the continuous distribution. Symptoms include chronic abdominal pain, weight loss, there is bloody diarrhea, abdominal distension, and tenesmus. Imaging show loss of haustral. Imaging shows loss of haustral marking, loss of haustral marking. Diagnosis is ulcerative colitis is confirmed by colonoscopy and a biopsy, which shows a characteristic cryptapsis. Potential complications of the ulcerative colitis are fulminant colitis, toxic megacolon, and perforation. This patient likely has toxic megacolon, which is a constellation of fever. This patient has fever. There may be tachycardia, fever, tachycardia, and there may be hypotension, leukocytosis, enlarged and dilated valve, and impaired colonic motility. So this patient has fever and dilated bowel, and treatment of ulcerative colitis is immunomodulator, biologics, corticosteroid. In severe cases, exploratory laparotomy and partial or total colectomy may be required, especially in cases of toxic megacolon. Okay.
Next. 36 woman comes to the office because of a 2-month history of what happened? 2-month history of mildly painful rash around her mouth and vagina, decreased sense of taste, and hair loss. Okay. 6 months ago, she underwent rule uncomplicated rule NY kite stick bypass because of obesity. Since that time, she has lost like 60 pounds. She has type 2 diabetes, hypertension, medication, metformin, and lodipine. She takes multivitamin inconsistently. She's 5 foot tall. BMI is still high. Her pulse is normal. Blood pressure is, I guess, normal. Exam shows a red scaling rash in the perioral and perianal areas. There is diffuse stinging of the air over the scalp. Cardiopulmonary exam is fine. Abdomen is obese and there is diffuse mild tenderness to palpation. Bowel sounds are normal. Supplementation with which of the following are most likely to have prevented this patient condition?
So decrease the sense of taste and decrease hair, decreased sense of the taste, decreased hair, and like decrease and dermatitis, triple D, decrease hair, decreased sense of taste, decreased hair, and dermatitis suggestive of zinc deficiency. Zinc is an important cofactor for numerous metalloenzymes throughout the body. Acquired zinc deficiency is rare but may occur in the setting of raw and Y bypass, raw and Y gastric bypass. As seen in this case, zinc deficiency typically presents with signs and symptoms of including disturbance of the taste, smell, hyposmia, hypogeusia, and neuropsychiatric disturbance, dermatitis, brittle hair, alopecia, paronychia, and delayed wound healing and immune dysfunction. Delayed wound healing, immune dysfunction. The dermatitis is often scaly and erythematous and may present with angular cheilitis, anogenital lesion. The diagnosis is confirmed by testing serum gene concentration. Testing serum gene concentration. Serum testing is also useful for excluding other vitamin deficiencies that are frequently concomitant in the setting of gastric bypass is vitamin B1, B2, vitamin B1, B12, vitamin A, and iron. And treatment is with oral zinc supplementation. Okay,
Can you read A?
yes.
I mean, so yeah. A. Mhm.
Copper supplementation is useful for treatment of copper deficiency. Copper deficiency is rare, typically occurs following gastric bypass. Signs and symptoms include myelopathy, microcytic anemia, neutropenia, peripheral or oral neuropathy. Mm, these patients' absence of focal neurological symptoms and peripheral neuropathy, as well as the presence of dermatitis, alopecia, suggest altered diagnosis. Okay.
Next, yeah. 32 men comes to the office because of episodes of sensation of racing heart, sweating, difficulty breathing and swallowing, and the fear that he's dying. His symptoms began when he started a new job 4 weeks ago. He has had 4 episodes during the past 2 weeks. He says the episodes are similar to episodes he had 10 years ago. He has a history of alcohol use disorder but has been abstinent for 2 years. No other serious illness, doesn't take medication. Father and paternal grandfather had alcohol use disorder. The patient is calm and cooperative. Pulse is fine, respiration fine, BP fine. Would be a bit low. Physical exam shows no abnormality. Mental status is engaging and says he has not felt he has not felt depressed. No, his affect is reactive and his thought process is goal directed, so no depression, I guess. Direct studies show a TSH hormone concentration of 3, which I believe is normal. Let me double check. Is normal. And T4 is 4. No, it's 5, which is normal. Which of the following is the most appropriate pharmacotherapy? Wait, what does he have again?
Fear of dying.
Like an- anxiety, panic attacks, kind of thing.
So in panic disorder, there is criteria, I think. So, uh,
Okay.
like there is fear of dying. There is a mnemonic called panic, but there is certain criteria in panic disorder,
Mm,
as far I remember. There is recurrent and unexpected panic attack with four of the following. Like there may be chest pain, palpitation, shortness of breath. This patient has like chest pain, palpitation, shortness of breath. This is one. And there may be trembling, sweating, nausea, chills. There may be dizziness and paresthesia and derealization and depersonalization and fear of losing control or fear dying and worry about the additional attacks and avoidance behavior. Got my point?
okay.
So four or more than four should be present. So this patient has fear of dying. So one, the episodes of similar alcohol, mm, calm and cooperative. On mental status, he is engaging and says that he has not feel depressed. So he is not depressed. He affect is reactive. He is goal directed. This is not the criteria actually. Okay, there are it does not fit all the criteria, but the symptoms look like panic disorder.
Mm-hmm.
So in panic disorder, first line drug is SSRI and CBT can be given. Okay, now I'm reading the explanation. So in panic disorder, four of or more than four of the following should be needed for diagnosing a case with panic disorder. Okay, panic disorder features panic attacks through unexpectedly are associated with worry about the future panic attack and avoiding panic triggers. This patient is likely experiencing recurrent panic attack consistent with panic disorder. Panic attacks feature acute fear or anxiety that peaks within minutes, is associated with four additional physical symptoms or associated mental status. These additional symptoms may include heart palpitation, tachycardia, shortness of breath, chest pain, dizziness, sense of choking, GI distress, paresthesia. So sweating, chills, trembling, derealization, fear of dying, or fear of losing control. Treatments typically include CBT and long-term SSRI, sertraline, short-term benzos are also prescribed to decrease the anxiety while waiting the few weeks that is typically takes for antidepressant medication to work. However, benzodiazepines are relatively contraindicated in patients with personal or family history of addiction. Okay.
Okay. Next. 42 women brought to the ED 30 minutes after the sudden onset of left-sided weakness, a moderate headache while exercising at the gym. She reports that the weakness occurred mostly almost immediately after the sudden onset of pain in her right jaw. Oh, that radiated to her right temple. She has no history of serious illness, doesn't take medication. She's awake and alert, temperature fine, pulse fine, but BP super high. Examination shows left homonymous myopia. The right pupil is 2 millimeters. I believe that's small, not sure. I think normal. And the left is definitely, I don't know, I don't remember. Both pupils are reactive to light. There is partial ptosis of the right eye and drooping of the left lower aspect of the face. Muscle strength is fine in the right extremities and 4 out of 5 in the left extremities. Oh, Jesus. Deep tendon reflexes is fine in the right extremities and is 3 plus in the left extremities. Something with the left. Babinski sign is absent on the right and is present on the left. Okay. Which of the following is the most likely diagnosis? There's something wrong with
So, what is your diagnosis?
I don't know, some kind of stroke.
No,
Uh, it's not a stroke. Mm, it's some kind of stroke, but it's affecting the right.
carotid artery.
E- okay, no, I guess it's carotid
Carotid
artery.
artery dissection is a very complex topic.
Yeah,
In
it
sorry,
because it sounds like a stroke, but not
yes, it
really.
sounds like a stroke, but it's not stroke.
Mm,
So this patient with sudden onset jaw pain, headache, neurologic deficit that begin while exercising, that begin while exercising, has a presentation consistent with carotid artery, uh, dissection. If you look at the inner circle of this carotid artery dissection, they actually give this point.
mhm.
Like
What,
after exercising.
what is it? Like risk factors or
No,
what?
go below.
Where?
I have seen where I have seen that. And there
I don't
is
know.
um,
I've seen the this
yes,
one.
yes, this one.
Scooter.
Like look at this. What is the next step in a young woman who runs a
Oh,
marathon?
right here. Right here, you're right.
Yes, in here and then look at the below.
Below, below, below. Oh,
What
right
is the
here.
yes? This patient, our patient, in the nbme question, this patient is exercising at the gym, and like the patient is on marathon, complaints of neck pain, headache, and right sided weakness, vision problem.
Mm,
So if this is given in this stem, then we need to think about the carotid artery dissection or carotid artery stenosis.
Mm-hmm, mm-hmm.
And
So
in
sport. Mhm.
yes, in trauma or spontaneously can happen, and hypertension is one of the risk factor.
Okay.
Hypertension, smoking.
No, for traumatic wait,
So for
for carotid.
dissection, I am talking about the dissection. In traumatic, the stem should be like it is compressing the internal carotid artery. Like somebody's the little baby is having toothbrush and he is fall over that toothbrush. So it is traumatic. But
Mm-hmm.
the dissection one, it may be due to trauma or hypertension or smoking, and there is like Horner problem, like ipsilateral partial Horner syndrome, and there may
Wait,
be
you're trying to wait.
sorry
You're trying to talk about the difference
dissection.
between the dissection and the compression. Is that what you're saying?
I
Or
am
you
trying to differentiate the carotid artery dissection and traumatic carotid injury.
carotid artery dissection and traumatic carotid edge? Okay, okay.
In a carotid artery dissection, there is ipsilateral partial Horner syndrome. Like this
Mm-hmm,
patient,
mm-hmm,
this patient has partial ptosis.
mm-hmm, mm-hmm,
So this
mm-hmm,
patient has Horner syndrome. This patient has like meiosis also. Right people is 2 millimeter and left one is 4 millimeter. So some sort of meiosis, partial ptosis is present,
mm-hmm,
and there is no anhydrosis.
mm-hmm,
And this patient has a focal weakness, left-sided weakness. So
mm-hmm,
signs of cerebral ischemia, focal weakness, which is a signs of cerebral ischemia, and there is ptosis, and mm, okay. So this fits with the carotid artery dissection.
mm-hmm.
But in traumatic, there is gradual onset hemiplegia, and there may be speech problem, there may be neck pain and thunderclap headache. Thunderclap headache like subacute, SH, like subarachnoid hemorrhage. We found the thunderclap headache in subarachnoid hemorrhage too. You got my point.
Got it, got it.
Okay.
Yeah.
Because in this stem, every like all the options are confusing.
Mm-hmm.
Okay. Now, so this patient with sudden onset jaw pain, headache, and neurologic deficit begin while exercising has a presentation consistent with carotid artery dissection. Carotid artery dissection is a common cause of stroke in patients in fourth to fifth decade, and may be associated with underlying connective tissue disorders such as fibromuscular dysplasia, Ehlers-Danlos syndrome. Carotid artery dissection is carotid artery dissection is usually precipitated by minor traumatic or mechanical event, exercise, cervical manipulation, coughing, weightlifting. The trauma leads to hematoma formation between arterial wall layer followed by dissection through the layers and luminal stenosis or occlusion, which ultimately produce the neurologic deficits caused by impaired cerebral perfusion. Patient frequently presents with ipsilateral head, neck, or face pain, or mm, ipsilateral head, neck, or face pain, or thought to be the result of nociceptor activation secondary to vascular distension. Other common symptoms include Horner syndrome, cranial neuropathy, symptoms consistent with ischemia to the anterior and middle cerebral artery distribution, and diagnosis is made by CT or MR angiography. Treatment is like that of patient with ischemic stroke and may include administration of the antiplatelet drug, alteplase, mechanical thrombectomy, and endovascular stenting. Okay.
Okay. Can you read all the other answer,
Yes.
please?
Cardioembolic stroke. Cardioembolic stroke occurs when a piece of intracardiac thrombus breaks off and embolizes to one of the cerebral arteries. Common risk factors include arterial fibrillation or atrial flutter, ventricular aneurysm, and/or mechanical valves. Patient's presentation depends on the vascular territory and may include hemisensory deficits, hemiparesis, ataxia, vascular deficit, dysarthria, vertigo, nystagmus, and/or cranial nerve deficits. While this patient, while this patient does have the evidence of cerebral ischemia, she does not have any known risk factor for development of cardiac thrombus, and her jaw pain and headache are not consistent with cardioembolic stroke. I don't get it. In cardioembolic stroke, it is associated with atrial fibrillation and flutter. Is that their meaning?
Yeah, like she will have some heart issues, but here her heart is fine. The
Fine.
pulse is fine. Hmm.
Okay, in hypertensive hemorrhage may show in the setting of long-standing uncontrolled hypertension or in the setting of acute hypertensive emergency. This patient typically caused by hemorrhage from small penetrating arteries in the pons, midbrain, thalamus, putamen, and caudate or cerebellum. Patients can present with headache, vomiting, confusion, altered mental status, stupor, or coma. Focal neurologic deficit depends on the site of the site of the intracerebral hemorrhage and can include hemiparesis, hemisensory symptoms, gauge, palsy, dysarthria, aphasia, or if in the cerebellum, ataxia, vomiting, disequilibrium. This patient does not have the risk factor for hypertensive hemorrhage, and her jaw and temporal pain would be unusual for a patient with these diagnoses. Subarachnoid hemorrhage most commonly occurs secondary subarachnoid hemorrhage most commonly occurs secondary to trauma or a ruptured intracranial aneurysm. In a non-traumatic setting, patient typically presents with acute severe headache, often described as the worst headache of my life, and along with the neck stiffness, photophobia, possible stupor or coma. In severe case, although this patient did have acute onset headache, her headache is not severe, and her neurologic deficits are more consistent with focal areas of ischemia rather than the more non-specific symptom associated with the bleed. And vertebrovascular infarct occurs with the impairment of flow to the posterior cerebral circulation and may not present with the vertigo, lightheadedness, disequilibrium, ataxia, and nystagmus. Mm, This patient does not have typical symptoms caused by ischemia to the posterior circulation, and her headache and jaw pain would be unusual in this setting. Okay.
Okay. Previously healthy 18-year-old primigravida woman at 22-week gestation comes to the physician because of genital lesions for 2 days. She's sexually active with multiple partners, but she has no history of STDs. Examination shows 1.5 centimeters painless superficial ulcer on the left labius major. There is non-tender firm inguinal lymphadenopathy. Serologic testing 8 weeks ago was negative for syphilis, Neisseria, and chlamydia. Which of the following is the most appropriate pharmacotherapy?
So, a variety of sexually transmitted infection may cause the formation of non-tender genital ulcer. There is painless ulcer and painless node. So, painless node, we know that it is syphilis. These include syphilitic chancre caused by a Treponema pallidum, lymphogranuloma venereum caused by Chlamydia trachomatis, subtypes L1, 2, 3, and granuloma inguinale caused by Klebsiella granulomatosis. In contrast, genital herpes and chancroid caused by herpes simplex virus type 2 respectively are both characterized by painful genital ulcer. Primary syphilis causes a shallow chancre with a clean base that may be associated with inguinal lymphadenopathy, which makes it most likely the diagnosis. In this patient, multiple sexual partner untreated syphilis develops in multiple stages with varying symptoms, including primary with a painful chancre caused with a painful chancre as described, secondary with fever, lymphadenopathy, and condylomata lata, mm, and tertiary neurosyphilis, tabes dorsalis, aortitis, goma. Okay, rest of the thing we know, like VDRL, RPR, FTABS. Do you want me to read the, sorry,
Yeah, what did you say?
like the rest of the thing we know, like in the syphilis, what is the treatment or what other
Mm-hmm.
complication can happen?
Okay. Okay, next.
Okay, next.
9-month-old boy brought to the office 9 months by his parents for a well child visit in late autumn. He was born at 34 weeks gestation via spontaneous vaginal delivery to a 34-year-old woman gravid at 2 following uncomplicated pregnancy. Medical history is non-contributory and he receives no medication. Growth and developmental have been appropriate and required vaccinations are up to date. As of his last well child visit, the patient is at the 50 percentile and weighs of length and weighs like 75 percentile. Weights at the 75, yeah. Vital signs are normal. Physical exam, no abnormalities. Which of the following is the most appropriate condition to vaccinate against at this time?
This question is very complicated for me.
The only clue is late autumn. That's the only clue
Yes,
you have. And then, well, I mean, they say he already received all his
all
vaccination.
his vaccination.
So that's also a clue. Um, I guess I was between RSV and
Respiratory
H.
syncytial virus does not currently approved have
Okay,
approved vaccine. Okay,
okay, then I guess no.
so it's not the answer then. Okay, influenza virus is an orthomyxovirus. Can you tell me the name of the paramyxovirus?
Which the wait,
Orthomyxovirus is influenza and paramyxoviruses are,
the RSV.
yes, RSV, MMR, measles, mumps, respiratory syncytial virus, and para-influenza, as far I remember.
MMR, measles.
I'm just recalling your sketchy
Yeah,
micro.
yeah, yeah, measles, mumps. Well, I saw MMR of measles, mumps, and rubella.
No, MMR is the vaccine, but
Okay,
paramyxo is measles, mumps, respiratory syncytial virus, and
MRIV, yeah,
para-influenza. Yes.
yeah. Mm.
Mm, okay. Influenza is an orthomyxo transmitted with respiratory droplet. Symptoms include high fever, chills, myalgia, malaise, headache, nausea, vomiting. Pneumonia may develop influenza A and B, seasonal pandemics. This can be particularly dangerous given their lack of protective antibodies. In children, in young children, this can be dangerous given their lack of protective antibodies. Complication of influenza infection is secondary bacterial infection of the respiratory tract and myocarditis. Influenza vaccination is recommended annually for all patients, including children above the age of 6 months. So it is very high yield, above the age of 6 months. Okay.
Okay. So it's given. What is autumn? Autumn is what? Spring, summer, or fall?
I don't,
I don't
you are
know.
asking.
I don't know.
I don't
Okay.
have an idea. Okay,
I have
you find which is autumn. Autumn at the heart.
Okay, so it's the same thing as fall.
Like
Okay.
winter.
Like wind. No. What did you say?
What is the fall?
I think okay. I think first thing like January to the first 4 months, January to January, February, March, April is spring. Then the next 4 months is summer, and then the last 4 months is fall. So it's spring, summer, fall. That's how it works here. And
Okay.
yeah, I think okay. So I guess fall is said in American English, while autumn is preferred in the but it's the same thing. Okay, got it. So influenza happens during the fall, so the last 4 months of the year. Sorry. Okay, so sometimes I get confused with those months. But I think when once they give you like a seasonal thing, it's influenza usually.
Yes.
Yeah.
But there is another thing I want to add. Like
Mm-hmm.
influenza has like both vaccine. It has like live vaccine, live
Mm-hmm.
attenuated intranasal vaccine, and it has inactivated vaccine.
Mm-hmm.
And the inactivated vaccine is given above the 6 months. Individuals age more than 6 months, inactivated vaccines are indicated, but for the live attenuated vaccine, healthy individual age 2 to 49 is the cut mark.
Okay, repeat it. Repeat what you just said. Everything that you just said.
Like
Yeah.
live attenuated inact intranasal vaccine, live
Mm-hmm.
attenuated intranasal vaccine.
Mm-hmm.
This vaccine is given in between age 2 to 49 years. Got my point? In
Yes.
healthy individuals with age range is uh, 2 to 49, because age less than 2 and age more than 50, the live attenuated one is not given, it is
Uh-huh.
contraindicated. But
Mm-hmm.
the inactivated influenza vaccine, it
Mm-hmm.
can be given in healthy individual age more than 6 months, like they have told us.
Okay. Got it.
And inactivated vaccine, there is no contraindication, only the severe allergy to the vaccine or its component.
Yep.
Okay.
Yep. Makes sense. Okay. Uh, 17 girl comes to the office because of a 2-month history of increasing severe pain below her left knee at rest and with exertion. She now has moderate difficulty walking because of the pain. She has no history of trauma or serious illness. She takes no medication. On exam, she is unable to bear her full weight on her left lower extremity. There is warmth and tenderness over the anterolateral aspect of the left proximal tibia. Okay. Peripheral pulses are normal. There is no evidence of instability of the ligaments of the left knee. Remainder of the exam is, including neurological exam, is fine. X-ray of the left knee is shown here. Which of the following is the most appropriate next step?
Without seeing the x-ray, is there any way to diagnose?
I cannot even diagnose it with the X-ray. Really. But I don't think I can even diagnose it with the X-ray. But nah,
We need to
um,
find out the way of finding the answer, because you will see the all the stems would be the approximately similar, but we will not gonna find the answer. So that is the problem. That's why uh, I try you find any clue. Like if you find the clue now, you will find the clue in the exam. That's why we are reading in this way. Like in the X-ray, In the X-ray, there is just like whitening of the anterolateral, like the tibia, whitening of the tibia. It in osteosarcoma, we know that there is a sunburst appearance. There may be Codman triangle. It is not look like that also. You find any clue in the stem?
Mm, for us, for the no. I mean, I guess the pain will be the clue, but no, not really.
Okay, okay, I'm reading the explanation. This X-ray is not similar to typical osteosarcoma
Yeah.
X-ray.
Mm, mm, mm.
Osteosarcoma is an if they actually told us, but the area, if we calculate, it is the metaphyseal area. So metaphyseal
Okay.
area is the osteosarcoma. Osteomyelitis and osteosarcoma is the metaphysis. So if
Okay.
you know the bone, particular bone area, so then it
Hmm?
one possibility of
I
finding
guess
out.
yeah, it will
Okay.
help you.
So it is characterized by osteosarcoma is the primary osseous malignancy in the pediatric children. It is characterized by cells with enlarged nuclei and and diagnosed enlarged nuclei and disorganized tissue structure sorry disorganized tissue structure that results of osteoid production, mineral congestion that provides mineral congestion sorry mineralized collagen that provides the structure of the bone. This malignancy is locally destructive to bone and can erode through the cortex. This results in periosteal reaction with elevation of the periosteum along the irregular ragged borders, an area of disorganized osteogenesis as seen in these patients. X-ray osteosarcoma typically occurs in the long bone. Osteosarcoma typically occurs in the long bone, often involving the tibia or femur. Initial presentation typically includes pain. Initial presentation typically includes pain and swelling seen in this patient, and or in some cases could also include fragility fracture. Osteosarcoma has high mortality high rate of metastasis to the lungs, or when undergoes adequate surgical resection. In this situation, initial staging does not detect the metastatic disease. In individuals of small groups of the cell have already metastasized yet remain below the threshold of detection. Diagnosis involves imaging studies and tissue sampling. In this case, initial X-ray should be followed by MRI of the lesion itself to facilitate the surgical approach for resection and biopsy. Treatment typically involves surgical resection combined with chemotherapy.
Can you read A and B?
Yes. Arthroscopy of the knee is minimally invasive. Arthroscopy of the knee is minimally invasive procedure often used in cases of ligament or meniscal injury, meniscal injury and osteochondral fracture. In this example, patient does not have a history of trauma or evidence of on physical ligamentum laxity on physical examination. MRI of the knee is the most appropriate next step. MRI of the knee is the most appropriate next step because cortical irregularities and periosteal reaction identified on the patient's X-ray. Okay,
And B?
sorry. Blood culture are routinely collected in patients presenting with sepsis to identify the presence of bacteria in the bloodstream. In the example, the patient presents with warmth and swelling of the knee but does not have signs of systemic illness such as fever, tachycardia, or tachypnea because the patient's X-ray findings are consistent with osteosarcoma. uh, MRI of the knee is the most appropriate next step. In case of septic arteries, blood culture would be reasonable. However, diagnostic aspiration of the synovial fluid culture would be uh, more appropriate microbiological test.
Okay, next. A 62 woman brought to the ED 62 because of 1 day history of severe abdominal pain 2 weeks ago. Severe abdominal pain. 2 weeks ago, she began taking amoxicillin clavulanate for respiratory tract infection. 1 week later, she had a fever, bloody diarrhea, and mild abdominal pain. She discontinued the amoxicillin and began taking over-the-counter omeprazole and loperamide for relief symptoms. Her symptoms have worsened, and she now rates her pain a 10 out of 9 out of 10. She has a 6 year history of type 2 diabetes controlled with diet. She was not taking any medication prior to the amoxicillin. She appears acutely healed. She's 5 foot tall and BMI is super high. Temperature is high, pulse is high, respiration normal, BP bit low. Abdominal exam shows distension and diffuse tenderness to palpation and voluntary guarding. The reminder of the exam is shows no abnormalities. Leukocyte count is super high. Test for CDEF is positive A. CDEF A. An abdominal X-ray is shown. Which of the following is the most likely cause of this patient condition? Hmm.
Okay, it is due to use of the opioid group of drug
Of the
like
opioid.
loperamide.
Okay.
C. diff, Clostridium difficile infection is an opportunistic. Uh, Clostridium difficile infection is an opportunistic and often hospital-acquired infection. Commonly occurs after the antibiotics due to loss of native colonic microbiota. These derangement in native microbiota presents an opportunity for the competition-free proliferation of C. diff, which produces toxin that results in dysfunction of the brush border and subsequent secretory diarrhea. C. diff infection are associated with the presence of pseudomembrane that appears as patchy regions of white mucosa on colonoscopy. The severity of the C. diff colitis can vary, ranging from watery diarrhea, abdominal pain with constitutional abdominal pain without constitutional symptom in mild cases to toxic megacolon, colonic ischemia, and severe sepsis in fulminant cases. This patient has toxic megacolon. This patient has toxic megacolon constellation of high fever, tachycardia, leukocytosis, enlarged and dilated bowels seen on the abdominal X-ray. So toxic megacolon can happen due to C. diff, can happen due to ulcerative colitis.
Mm-hmm.
Loperamide is an opioid receptor agonist, acts in the large intestine, decrease the colonic musculature activity. The use of loperamide can slow the colonic motility and clearance of the fecal matter, causing prolonged exposure to C. diff toxin and increasing the risk of severe infection of toxic molecular treatment of C. diff colitis include discontinuation of the any offending agent, oral or rectal vancomycin, use of oral or rectal vancomycin and oral metronidazole, fidaxomicin, and colectomy depending on the severity of this patient's infection. Okay.
Wait, what? Which one is the antibiotic that causes C. diff? The most likely that causes C. diff is,
The most common antibiotics.
yeah, that causes the C. diff.
Any mostly like what can I say?
Was it one that causes that mostly causes it?
Sorry,
I feel like I feel like there is one that mostly causes the C. diff.
is it ciprofloxacin?
No. Oh, am I wrong? There was one that's usually like associated with, oh, when you take it, they have more chances of getting
A-
C. diff.
Any infect like any antibiotic which clears the like antibiotics clear the normal
This one,
flora. Sorry.
clindamycin. Clindamycin.
Okay, clindamycin. Yes, yes,
Yes.
clindamycin.
Okay. But you're right. It says that other antibiotic like penicillin or amoxicillin and cephalosporin can also cause it. But usually clindamycin, that one clean. Okay. Got it. Got it. Got it. Okay. Next. Randomized control trial conducted to assess the risk and benefits of surgery compared with pharmacotherapy for the treatment of symptomatic high-grade
And
carotid
another thing like Clostridium can
mhm,
cause neck fash, like necrotizing fasciitis.
necrotizing fasciitis. Okay, okay,
Like
okay.
Clostridium myonecrosis, gas gangrene. It can cause gas gangrene. It can cause necrotizing fasciitis. Okay.
But that's not Clostridium difficile. That's like this one, right?
Yes.
The
Clostridium
preference.
difficile is like it causing the watery diarrhea after getting the antibiotic.
Yeah. But the
Oh,
gas gangrene is the Clostridium perfringens.
yes, Clostridium perfringens can
Okay.
cause the gas gangrene. Yes.
Okay. A randomized control trial conducted to assess the risk and benefits of surgery compared to pharmacotherapy for treatment of high-grade carotid stenosis, carotid artery stenosis. Total of 3,000 patients are randomly assigned to either undergo surgery or pharmacotherapy. After excluding 98 patients who died during the surgery, the investigation found that surgery is associated with 48% reduction in stroke. Which of the following raises the most concern regarding the validity of this conclusion?
Okay. One thing I want to add. Go to the previous X-ray.
Previous X-ray. Uh-huh.
If how can we diagnose just looking at the X-ray of this patient having toxic megacolon? If it is more dilated, if the dilatation is more than 6 centimeter, I know it is not possible to find out the 6 centimeter, but if we have like a scale and we can measure, like if the dilatation is more than 6 centimeter, like severe dilatation,
Mm-hmm.
so it is toxic megacolon.
Okay.
So severe dilatation and the loss of hostra, like
Lost.
there is loss of hostra, these two things. In normal large bowel, there is hostral folds, but in toxic megacolon, it is severely dilated, so more than 6 centimeter, and loss of hostral fold. Okay, because sometimes we may not find the clue.
Okay. Got it. Got it. Okay. Oh, which of the following raised the most concern regarding the validity of this conclusion?
Lack of use of intention to treat analysis. What does it mean? Can you explain?
Oh no. Wait, read the explanation first, then I'll try to explain.
Okay, I'm reading the explanation and you will explain because biostat is going up from my head. Okay, so mm, The most obvious and potentially concerning issue with the study design is the lack of intention to treat analysis. Intention to treat analysis is a method of statistical analysis in which all subjects randomized with who are randomized within a study are included for analysis in the treatment group to which they are originally randomized, regardless of what treatment they eventually received. These differed from per protocol analysis, in which subjects are analyzed according to the treatment actually received. In general, excluding randomized subjects from analyze introduce introduces bias and decrease the prognostic benefit of randomization. ITT, intention to treat analysis, is always for preserving the integrity of the randomization and for limiting the effects of certain forms of bias, particularly attrition bias, that may result from patients who did not receive the treatment, receiving the wrong treatment, stopped treatment early, or dropped from the study. In the example scenario, patients who died during surgery are excluded for analysis. Excluding these patients from analysis greatly increases the likelihood that our erroneous conclusion will be reached regarding the effectiveness of the procedure under the study. Okay, I don't get it. May explain me.
No, I think here it will help to just discard the other answers.
Like,
Like for example, like we know they are trying to compare surgery versus medication for carotid artery stenosis, but then a lot of people die from the surgery, but they're still saying that, oh, the surgery is better than the medication. So they're asking what can be wrong in this study. You know, it's not low prevalence of carotid artery stent. That's not the answer. We already know that because there is. I mean, they didn't talk about the prevalence or anything on this study, so this is not the answer. It's not low statistical power because low statistical power will be them having a small number of patients, and they have like 3,000.
3000.
So yeah, so it's not that. It's not misclassification of stroke because they didn't even talk about what kind of
Classify
stroke they classified. Yeah, they just say reduction in stroke in general. They didn't really talk about anything specific about what kind of stroke. And then we know it's not observation bias because uh, here they didn't really talk about how they did the study, if they blinded the placebos or they blinded this and all that. So I don't think there is any kind of bias here. I mean, we can read option E, but they didn't really talk about how they did the experiment, how they, yeah. So the only thing that makes sense here is A. Now, also, there A, intention to treat means that you're adding everybody, regardless of if they died or if they received the medication or if they left before the study was completed, you add them in the study. And then per protocol, remember it means that people that receive the medication or the surgery are the people that are counted in the study. If you did not receive or you left early or you die or whatever, you are not counted on the study. So they are talk based on that. That's the only thing they really are talking about in the question. Like these people receive it, these people didn't receive it. I think that's kind of what they're trying to say. They're saying that the explanation basically saying that because they didn't count the 98 people that died, so their
yes,
conclusion may be wrong because they didn't count those 98 people that died. Maybe it's the surgery that killed them,
yeah.
and they're not
Maybe the
counting it.
procedure,
The procedure, yeah, and they're not counting it. And now they're saying, oh, the procedure is good, but
yes,
you didn't count the 98 people that died. So they didn't use the intention to treat. They used the per protocol where they remove the people that died. So the problem here is the lack of use of the intention to treat, where
Intention
they
to
add,
treat
yeah,
analysis.
where they add everybody. Doesn't matter if you die or if you do not receive the drug or whatever. I think that's, if you want to go with the explanation, that's the explanation. But I
Yes.
think I would have just removed all the other ones, and that would have been the one that would have been left. That
Okay.
makes sense.
Yes.
Can you read E?
Yes.
Yes, thank you.
Observation bias is incorrect. Observation bias occurs due to discrepancies between between the observed between what is observed or recorded by the investigator and what is actually present. This form of bias can occur due to investigator expectation and hopes. Investigator expectation and hopes regarding the treatment under the study. Blinding mechanism, use of placebos and analysis of inter-observer variability can help to reduce observation bias. While observation bias may occur in a study where a new treatment is being evaluated, the obvious issue with the explanation with most obvious issue with the example scenario is exclusion of some patient from analysis due to lack of intention to treat analysis. Okay.
Okay. Next. 25 men being observed in the ED after he was evacuated for a mountain from a mountainous area while backpacking alone during the snowstorm. The wilderness search team found him 2 days after he lost his way. The patient was wearing wet clothing and he was cold, confused, hallucinating. Initial vital signs were pulse was super low, respiration super low, blood pressure super low, inclement weather, delayed helicopter access for 6 hours. Field treatment included removal of wet clothing, warming with layers of dry clothing and sleeping bags, and later administration of warm liquids. On arrival to the ED, the patient was alert and fully oriented and shivering. Vital signs were core temperature, I guess, was a bit low. Pulse normal, respiration normal, blood pressure was a bit low. The patient's feet were cold to touch and mildly red from ankle to midfoot. There were mixed erythematous and pale areas as well as mild edema. There were several small blisters filled with bloody fluid over the proximal toes. Sensation was poor in both feet. No gangrene was present. The patient's feet were immersed in water with temperature of, yeah, this one, 42 to 40. Yeah. Now, 6 hours later, the patient reports severe pain in his feet. The feet are hyperemic to midfoot with numbness in the ankles. Distally, his feet are pale and have more dark blebs. The patient is worried that his feet then asks what will happen. Yeah, he's worried about his feet. At this time, this is the most appropriate thing to tell him. At this time, it is most appropriate to tell him which of the following. Sorry.
Okay. Very complex question.
Yes, yeah.
So this patient's injury is severe, but the extent of the tissue loss cannot be determined in case of frostbite. Frostbite is the result of skin and soft tissue exposure to severe cold temperature over time. Vasoconstriction occurs in the affected over time. Vasoconstriction occur in the affected skin, leading to decreased blood flow to the areas of the involvement. As the temperature of the skin drops, hyperviscous blood from microthrombi and microvascular injury occurs. Site as highest risk for frostbite include the ears, nose, mouth, and distal extremities. In extreme temperature, frostbite may occur within minutes to hours. Predisposing risk factors include predisposing mm, the risk factor include peripheral vascular disease, smoking history, Raynaud's phenomenon, frostbite injury may cause irreversible injury at sites of microvascular inflammation, at sites of microvascular thrombus, and irregular and reversible injury at the site, reversible injury at sites where there is stasis but no occlusion of the blood flow. Management include removal of the patient from cold exposure, rewarming the affected patient. Adequate painkiller. Extent of the frostbite injury takes hours to days to fully assess, and local wound care to prevent soft tissue infection, and to recommend for patients who develop frostbite. For patients with tissue necrosis, debridement and delayed amputation is required. Okay,
Can you read A and B? I mean, B and C, like
yes.
the first one. So yeah.
Further improvement with further uh, further improvement will be rapid with fully recovery expected, and a good recovery is likely, but a better determination cannot be made for 2 to 3 days are unlikely. This patient's presentation is suggestive of vascular occlusion, and physical examination showed distal pallor and purpura. Based on the clinical presentation, subsequent tissue necrosis is likely. He is likely to require amputation of both feet and cannot be determined based on the patient. Oh, sorry. Positive prognostic indicators include restoration of the blood flow to the midfoot and hyperemia at the site where blood flow has been restored. While this patient may develop wounds secondary to vascular occlusion of the affected site, need for subsequent bilateral amputation cannot be determined at the time. Okay,
Okay. Next.
so find out the margin. We need at least 2 to 3 days.
Why you say that? I don't understand.
Like, look, the better determination cannot be made for 2 to 3 days are unlikely. Like these patients, there is frostbite. This patient's injury, the extent of the injury that cannot be determined in this patient, isn't it?
Okay. Uh-huh.
So, as the extent of the injury cannot be determined, so our decision either like restoration or the amputation, this decision is taken after the measurement of the extent of the tissue, isn't it?
Okay. Uh-huh.
So, for this, we need at least 2 to 3 days to find out the margin of the,
Why do you say 2 to 3 days though?
like, 2 to 3 days. I have said, like, look at the option A and B.
Uh-huh.
They said that, but a better determination cannot be made for 2 to 3 days are unlikely.
Okay,
Good.
so that means that's not the right option,
Okay,
right?
that not the right. Okay, sorry.
Uh-huh.
I am
I mean,
fine.
if you
Yes.
here it says it on the explanation, it does says like hours to days, but it didn't really specify like 2 to 3 days. Um, but it just
So
says
my
it
thinking is like how much we need to wait,
to wait. Yeah, I don't know.
because everybody will try to know about the answer, that what would be the
Because
next step.
because I remember we did one question like this in
Yes,
your, and it wasn't days. It was like it may take weeks.
yes, it
That
take weeks. Yes.
yeah, it was like it may take weeks. I don't think they did. They say the specific number of weeks, but they say it may take weeks. So I never found a question where they say specifically like it's going to take 2, 3 days or 5 days or whatever. But so it can take weeks or days. So I don't. That's why I think that
And
B is like.
that question, like there is another option, like thrombolysis can be done.
Mm-hmm. Mm-hmm. Yeah. So I think this B was too specific. Like in 2 to 3 days, it was too specific. Like we cannot know that we'll be able to make an assessment in 2 or 3 days. It was too specific.
Okay,
Yeah.
makes sense.
Yeah. Mm, okay. Next. Oh, I need my breakfast.
Okay, okay,
Which-
you go to have your breakfast.
okay. Your phone.